stand by. Well, good day, everyone, and welcome to the Utilizing an EHR in an Orthopedic Practice and Attesting for Meaningful Use conference call. Today's conference is being recorded, and at this time, I will turn the conference over to Ms. Holly Wilson. Please go ahead, Ms. Wilson.
Thank you very much, Kelsey. Hello, everyone, and thank you for joining our webinar today. My name is Holly Wilson. I work in our marketing department here at McKesson, so we do appreciate you taking time today to join us for this webinar. We're very excited today to have our two speakers. We have our guest speaker and McKesson customer, Nabil Razzouk, as well as our educational specialist, Philip Wilson, who will talk about Stage 1 and Stage 2 of the Meaningful Use program. Before we begin, I do have a couple of housekeeping items that I would like to cover. As Kelsey, our operator, mentioned, this webinar is being recorded. After the webinar, both the slides and the recording will be available to registrants via email, so we'll be sending an email out with links to both of those. And then we will also be opening up the webinar to questions at the end, so be on the listen for that Q&A prompt. So now I would like to go ahead and welcome our guest speaker, Dr. Razzouk, who is our the CEO of Arrowhead Orthopaedics, which is a 7-location multi-provider practice located in Southern California. Dr. Razzouk has extensive experience in healthcare technology and specifically with electronic health records. We are excited to have him here with us today. And just a couple of things, background on Dr. Razzouk. I'm sure he will give you some background as well, but I just want you to know that he has been the CEO of Arrowhead Orthopaedics since 2002. He received his MBA from Andrews University in Michigan, as well as his Ph.D. in Marketing and Social Psychology from Arizona State University. In addition to a long and successful career in academia as professor and department chair of marketing, Dr. Razzouk has consulted to various industrial and service organizations and conducted executive training programs domestically and overseas. So now it is with great pleasure that I welcome Dr. Razzouk.
Thank you, Holly, and it's good to be with you. Thanks for the introduction. I am Nabil Razzouk, and I am the CEO of Arrowhead Orthopaedics. And as Holly mentioned, this is really the premier group of orthopedic surgeons in the Inland Empire, which constitutes the two largest counties in the United States, San Bernardino and Riverside counties. Currently, the group is made of 24 orthopedic surgeons representing the various subspecialties in orthopedics. We have 2 pain management physicians, 4 physician assistants, 7 PT and OT professionals, and we currently have about 165 support staff working out of 7 different offices. The group first implemented an EMR system in 2003. I had just joined the organization at that time, and the decision was made before I joined to go ahead and bring in the Altier software into the organization as our first EMR solution software. We had that for about 6 years. We were trying to work with Altier at that time to make sure that they're going to be CCHIT compatible as well as prepare for meaningful use. We were having some issues because a small organization based on venture capital was having some difficulties, and we wanted to be prepared for the next route or the next phase of interconnectivity. And so we decided that it was time for us to start looking for a second-generation EMR, and we started our search accordingly. But we wanted to make sure, having made the commitment for meaningful use, that whatever system that we would have would really take us through the next stage. So after a long and extensive search and evaluation of several EMR systems, our group selected Practice Partner, which is a McKesson product, and as I know that it's a road less traveled, but definitely for us it has been a good journey. By the end of our first year with Practice Partner, we achieved 100% physician compliance, and we cut back our dictation and transcription costs by 60%. I have with me here Lori Byers, who is the clinics director, and she always reminds me of how much money we have saved with Practice Partner. In 2011, we successfully completed the attestation for the first phase of meaningful use, and last month we got our first pre-checks towards meaningful use. These are the $18,000 payments per participating physician for the first phase of meaningful use. I understand there are a couple coming by here in April as well, so they'll be coming through as payment for the first phase. Over the past 12 months, we have more than doubled the size of our group. We went from 11 to 24, and now we have offices, as I mentioned earlier, 7 offices in the 2 counties, and all of our physicians are utilizing Practice Partner with minimum initial training. It's been really interesting to know that the new physicians joining us, some of whom have worked with other systems, coming in, have noted that hey, this has been an easy transition for them. I wanted to just join with my colleagues who are out there looking at trying to consider this decision. How would we go about it? And I went back over our experience in here. Some of us start with the problem of, well, we do need to bring in a new EMR or bring in an EMR for the first time. Obviously, talking to a lot of my colleagues over the past several years, this is not something that we have easily decided on, that, well, we need an EMR. I think there are a lot of us to this day who are fighting the process, fighting this decision, claiming that, hey, we could do without an EMR. But in the conferences I've been going to lately, we're finding that these voices are fewer and far in between. So, like any other decision situation, once we recognize that we do need to bring in an EMR system, we have to start looking for information. And as we would see, the type of information that we were finding ourselves going after, well, what is available out there? What are the various systems that are available? So that's the alternatives or the options. And as we were going through the process, we learned to identify some of the evaluative criteria, what questions to ask, because a lot of us don't really know, what we should be looking at. And as we would know, most of the sales reps come in and they'll put on a dog and pony show and would make you think that this is something you wouldn't want to leave without, and that you would want to sign on the dotted line that same day. But that's not always the right thing to do. And so, we went through the process of searching for information, looking at all that's available out there, making the decision, and evaluating that as we go through. Now, I always say that a problem is really the variance between a desired state and an actual state. Our physicians, and I'm sure that it is that way in almost all of orthopedics practices, our physicians in this specialty are a lot more gadget-oriented, and they really like to be on the cutting edge. And so our physicians, let us know that they do want to be forward in the adoption of EMRs, and we accommodated that. As I mentioned, again, some of us in administration at times would look at this as something that maybe we can postpone another year. And since even meaningful use was not to start or would extend the first year to the first phase through 2012, why do anything before then? But this is 2012, and I think EHRs and EMRs are here to stay, and there are some rewards, some incentives coming from CMS as well as from Medi-Cal programs, which I'm sure that'll be talked about a bit more in the next presentation. I would say for those of us who believe that medical records, electronic medical records will slow us down, and initially they do. We have to admit that and manage our expectations accordingly. I think now we are presented some incentives to adopt EMRs, but even if we were not, I would definitely recommend an EMR to any organization that wants to maintain relevance and be here next year and the year after. So, once that decision is made, we would take the plunge and we would start looking, and that's what we did as well. Normally we start with what we know. Having gone through the first phase or the first EMR that we had, we knew a little bit more. We've had some experience as to what we wanted and what we didn't know. We find that the less decision makers know, the less confident we are about our own judgment, and the more likely we are to fall into this group think. We just go to others, find out other physicians, other administrators at times, and you'd want to depend on their experience. Some of you are on this webinar today to learn a little bit more, but I hope that you would also take into consideration your needs as you should. This is a high involvement decision. We didn't get it for free, and I doubt that you would get your EMR for free. Some of us in administration, and I've had at least 3 colleagues who have lost their jobs on account of making the wrong decision for an EMR, and so it is a decision that we have to make with quite a bit of contemplation. However, I have to say that going with the majority is definitely a risky strategy. Even just this past week, talking to some of my colleagues about what they're doing, and they just mentioned 1 or 2 products that they have looked at just because they are the big names in the industry. And I know very well that some of the bigger names in the industry these days are not ready for second phase of meaningful use. They are not considering accommodating the e-links that would be necessary to work with some of the health exchanges that are coming on. Well, I'm sure that those of you who are signed on this webinar today are looking for some information. I'm sure some of you may have looked at the class list. You may have looked at what COA has put out, what the CMS has put out, got some recommendations from colleagues. It's always a good place to start, but that should not be the limit. And then as far as, the evaluative criteria, what is it that we should be looking for? What questions to ask? If this is your first time around making the decision, again, hopefully you'd get some pointers today and that you would seek some more information in this regard as well. I know that evaluative criteria might be different for administrators from those of physicians. And we'll look at both of these groups. They're both decision makers and influencers in the purchase decision process. And I always assert that, whether it's administrators or physicians, we don't buy products. And I always tell salespeople, don't sell me the steak, sell me the scissors. Don't come and sell me software and hardware. Sell me a solution to our connectivity, to our communication, to our note taking and note management process and so on. So I always say that people buy 2 things and 2 things only, and those are good feelings and solutions to problems. And so if you could, if a product or a system would help resolve our problems and we would feel good about the people who are doing business with, we're sold, and we would tell a lot of folks, and this is why I'm on here today, because we felt that we've had the solutions to the problems that we were looking for, at least most of them, and we definitely feel good about the people that we have worked with, both at McKesson as well as at Stanford Technology, who are our VARs, the value-added resellers who've done a good job for us as well. All right, so what do administrators want? What are they looking for? Increased efficiency, which means reduced labor costs. I know starting 1 month after the implementation of our first EMR, we were looking at how many people would we let go of. We could reduce labor. The simplification of processes, so people would feel better about not doing things that they feel there's no need for. Improve communication with referring entities. This is definitely important to administrators, and as we find out also for physicians. Our referring base, be it primary care physicians or adjusters and others that we do business with workers' comp, want more communication rather than less, and whatever system you implement should definitely facilitate greater communication capabilities. Improve coding, billing, and collection processes. And if there's no other reason really for implementing an EMR in the PM system than to achieve efficiencies in this area, I would say it's definitely worth it. Improve communication within the practice. This is just as important as communication with referring entities and outside entities, and it does enhance efficiency significantly. Full participation of use of the system by the providers. Again, a lot of CEOs have lost their jobs primarily because they implemented systems themselves. They made the decision because they were dazzled by reports and dashboard of reports and so on, and they bought the system only to find out the physicians would not use it. And if the physicians don't use it, you really don't have much of an EMR system. So from an administrator's perspective, it's music to my ears to find that the physicians are using it, and beyond that, it becomes a lot easier to achieve the efficiencies that are desired. Pricing is definitely a factor, and reasonable pricing is definitely something that's touted by almost any of the vendors these days. The e-link capabilities, this is something you may not hear that much about from a lot of people that you may talk to, but I have been very involved in the development of the local Inland Empire Health Information Exchange. This is going to be a very significant component in interconnectivity within the state as well as nationwide, and that is a requirement for the second phase of meaningful use. Sadly, a number of the large vendors or vendors of big name EMRs have selected not to develop these capabilities for e-links. This means that you may not achieve enough efficiencies when you're linking to other groups, your labs, the hospitals, and so on. You may find yourselves having to pay a lot more for each of those links than if you had the e-link capability, and I know that McKesson does. So that's definitely a plus for the practice partners. The company would be around for the next decade. That is definitely, again, another important criteria to look at. The first time around, we were not paying much attention to that, and we went with what we thought looked good and would do the job, but only to find out that the venture capital company we were dealing with as the vendor for our first EMR was struggling financially. And so the second time around, we put that on our list. We want to make sure that we would deal with a company that's going to be around. And one of the selling points we had for McKesson was this is a huge healthcare company. It's been around for decades. We know that they will be here. We got a commitment that they are going to be investing in product development over the next several years, and we felt comfortable with that. So these are really important criteria at times we may not think of, but this is not a decision I want to make in 2 or 3 years, again, just because a company that we were doing business with went out of business, or, as is the case with some of the smaller companies now, they are putting themselves up for sale. One of the ones that keeps being touted all the time as an orthopedics-related system is up for sale. And you never know what's going to happen once that company is sold to another. And definitely administrators want whatever system that they buy into to make them look good and to protect their jobs, and I don't hide that at all. I think it's important that we pay attention to that. Well, what is important to physicians? Again, I say physicians don't buy EMR systems, they buy good feelings and solutions to problems. And so what would make them feel good? What would be the type of solutions they're looking for? Ease of use. Lori keeps reminding me, and the physicians do as well, that the less screens, the better, the less clicking they have to do and moving around, that's more efficient, and that's what they would look for in a system. They want something to enhance the physician's interface with the patients. Physicians like to be able to interface directly. They don't like the whole idea of sitting down to type anything in front of the patients. And so the more of that they have to do with any system, the less likely that they are going to fall in love with that system or use it sufficiently. Physicians want integration with other digital apps like PACS, the PACS system, the hospital EMRs, the labs, and that's again where the e-links become essential. Convenient access to gadgets like iPads, iPhones, and again, that's something that I believe McKesson is moving on with. And then something that does not slow practice down or decrease revenues. And last but not least, at least on this page, be flexible to allow different physicians the ability to customize to fit their practice style. This is a very important criteria. I have 24 physicians, but I would bet that every one of them has a different practice style, and this is one feature that screamed loud and clear to us that, hey, this is really great. This is going to allow us to increase participation by our physicians. Next, we wanted something to meet the requirements for reporting and interconnectivity. And most systems, by the way, these days would meet those requirements. Something that's reasonably priced, and then allows for faster, more accurate, and regular communication with referring entities. That's something you hear from your physicians all the time. And physicians like good software support and definitely continued investment in the product. And one last thing, something that would improve the quality of life for the physicians. I've heard it from many physicians saying, I have a family. I like to be able to go home and eat dinner with the family, which meant the more flexible the system is, the more user-friendly it is, the greater is the likelihood that the physicians are going to use it and then be able to go home and spend time with the family. Well, just quickly going over how this process worked for us. As I said, our first generation EMR vendor was having liquidity issues. We were concerned about the sustainability of that organization and their qualifying for meaningful use. And so we started our search. I know I went to about 5, if not more, EMR selection seminars put on by the CMA, the COA, some other private organizations as well. We reviewed over 15 different EMR systems, and then we invited 9 vendors for demos and presentations, and then we had about 4 to 5 site visits. And some of these were a joke to remember. We had one sales rep who was so excited about the product that he took us to one of his favorite sites. We drove about an hour and a half, got there, and almost every question that we asked, well, how do you use this aspect? Oh, we don't use that. Well, how do you do this instance? Oh, we don't do that. And so we came out very perplexed. This is the show site. Something is really wrong, and we're glad we just got out of that. That was a strong message, forget it. But coming after a presentation that was so extensive, again, with razzling and dazzling facts from the sales reps. We were very, very disappointed with the product when we saw how it was not used in the real world. Another sales rep took us to another site, and here we have the physician who's making the presentation and the demonstration of the product would whisper in my ear, said, "Follow me to room 6. So I go for him to room 6, only to be told that don't touch this piece of crud, don't take this product. And so we had these type of experiences that luckily, swayed us away from products that we probably would have been disappointed with. And then we narrowed the list down to 2 vendors. And something that's very, very important, we engaged the physicians throughout the process, but more so as we came to the final stages of the selection, I wanted this to be the physician's choice and not the administrator's choice. We liked one particular system. That was SRS. We thought that was really neat, but it did not have a PM system to go with it. And so we started to search again, what can we find that probably would provide that level of flexibility to the physicians that they would accept. Talking to one of our colleagues, he was a PCP, a primary care physician, he suggested that we take a look at McKesson's Medisoft, which is really a basic product for maybe a 1 physician office or a 2 physician office. But we soon recognized that was not acceptable. We moved away from that. But in talking to the sales rep, he was insightful enough to recognize that we needed something that was a little bit larger and more robust. And that's when he suggested that, well, maybe we should look at this other McKesson product, which we have never heard of to that point. What is the other McKesson product? Well, Practice Partners. So here we get introduced to the concept of Practice Partner as well as to the concept of the VAR at that point. And we were delighted to have made that choice. I'm trying to move. Okay. What we have learned from this process. Number 1, really, the EMR selection process must be made by physicians and not administrators. An acceptable EMR system must offer flexibility to accommodate different physician practice styles. You're always going to have somebody saying, I don't like the way this is. Fine. Okay, so you want us to develop your own templates? Do you want drop menu? Do you want whatever it is? Could be worked out within the system. And those who like, for instance, the integrated Dragon, okay, which is a very nice feature in Practice Partners. Others don't, but again, it should be flexible enough to accommodate everybody. We learned that all that glitters is not gold, and there's a lot of glitter in the EMR world, especially with sales presentations. You really need to see the product in operation, and don't just make a decision to buy any product on the basis of just the sales presentation. Beware of the salesman who brings donuts. And, some do, and we find that the less acceptable the product, the bigger were the donuts, and the more often they brought them. Relationships matter, and it helps to have a responsive team that you will be dealing with. That's important, beyond purchase. Once you sign on the dotted line, what matters starts then. Really, having people call you back, having people work with you from A to Z to achieve a successful installation, and that's very important. And I say relationship because this is a relationship, it's a partnership. This is a road most traveled, maybe the safer route to take, but not necessarily the most scenic or the most pleasant or the most efficient. So again, this product, Practice Partner, may not be on everyone's radar screen out there, but I would say take a good look at it because it has a lot of features and benefits that others may not have. All right, what else have we learned? Trying to, all right, yes, this is the word. Select an implementation team. Once you make the choice as far as implement your product, assign a leader, get out of their way, but, maintain constant communication with them, allow staff sufficient time for training. I think that's very important. Don't expect to have a product installed and have everybody work on it the same week and be as efficient as ever. I don't know of any single situation where something was implemented and some efficiencies were lost or were not lost in the process. Anticipate specific and varied needs of providers. They're all different. If you want their participation, you have to come up with a product that has the flexibility that practice partner does. Manage expectations throughout the process. You have to tell physicians from day one that things are going to be slow for a while. What we have done to facilitate the successful implementation was to add another MA to work with the physicians as a scribe, and that has really enhanced the lifestyle of the physicians and it has enhanced the acceptability of the product. Celebrate your successes. Keep exploring the capabilities of your EMR. We keep learning all the time. Keep listening to your staff. The staff could come up with good ideas often and maintain direct communication with your vendors' product development group. I think that's essential, and we like the fact that the people at McKesson, listen. They like our ideas, and they have a venue that we get ideas from the physicians, from the users, that we pass on to them for the next generation of improvements. All right, this is a little about our story and our history with McKesson, with Practice Partners. And thanks for the opportunity to make this presentation. All right, Holly, I get back to you now.
Yes, thank you, Dr. Razzouk. Thank you for sharing your experience in how you went about selecting an electronic health record. I believe the real-world examples that you've provided and lessons learned will be helpful for our audience as they're making their own selections. Dr. Razzouk will be available for Q&A at the end of the call, but before we get to that, I do want to take a few minutes to turn the call over to Philip Wilson, who is an education specialist at McKesson, and Philip is going to provide an update for us on meaningful use stages 1 and 2. So, Philip, please go ahead.
All right, thank you. Hello, everyone. I am an education specialist with McKesson, and I'm part of what we call the Meaningful Use Strategic Team, which is just a cross-functional group of us here at McKesson that are focused on meaningful use. We all know meaningful use really well. We meet fairly regularly to talk about meaningful use issues and help our customers solve issues that they're having meeting meaningful use. So that's what I've been doing for the last few months. So let's talk a little bit about what meaningful use is. So it was part of the American Recovery and Reinvestment Act of 2009, signed into law in February of that year, and it was part of the Health Information Technology for Economic and Clinic Health, or HITECH Act. And really the purpose of it, there were 5 main goals of meaningful use. They wanted to improve quality, safety, and efficiency and reduce disparities in care. They wanted to engage patients and families, improve care coordination, improve population health, and ensure privacy and security. So those were the main goals. And in order to get people to buy into the concept of meaningful use and to get physicians to adopt an electronic health record, they figured we needed to offer some incentives and maybe some penalties. So the impact of this is that there are incentives and there are penalties. We think of it as sort of a carrot and the stick. The incentive started last year, and if you adopt an EHR and use it in a meaningful way, the government will give you incentive payments for doing so. If by 2015 you have not adopted an EHR, they will begin to penalize you based on your Medicare reimbursement. They'll actually reduce your reimbursement payments. So the goal, what they're really looking at, is to try to get 70% of physicians to adopt an EHR by 2014 and 90% by 2019. So they're offering a lot of money if you're willing to adopt an EHR, and if you're not willing, then they are certainly willing to consider penalties and reduce how much you get paid on some of your claims. So they set up the Meaningful Use program, and currently there are 3 stages. There may be something further beyond stage 3, but for now they've set up 3 stages, each with its own specific goal. Stage 1, they're really looking at the electronic capture of patient data. They want people to obviously, really we ought to consider the fact that they just want to get people to adopt an EHR if they don't already have one. And part of that adoption process is then, of course, using it. And so stage 1 is not terribly difficult. Really, they're just looking for users to start capturing patient data. And once you get to stage 2, and the stage 2 rule came out in February of this year, they're looking at improved clinical processes. Okay, not only are you capturing data, but you've improved the way you're caring for your patients. And then stage 3, which will be coming in the future, they're looking for quality measurement and improvement. So they want to be able to take a look at your raw data, really, and be able to say, you've improved the quality of care you're providing, and we can measure that. We can actually look in your data and determine that you're taking better care of your patients. So the final rule, Meaningful Use, came out last year, actually the year before, I'm sorry, and they looked at just getting some data captured. They wanted to just people to get on the EHRs, begin putting their data into the EHR, and so that's the current stage. And then stage 2, they're really looking for improved clinical processes. They've increased the demands on physicians for stage 2. You have to do more. And obviously, if they're looking at stage 3, they're going to look for some improvement, proof of improvement, I should say. So there are basically 2 different programs available under Meaningful Use. The first is Medicare, which I think the vast majority of physicians are going to choose. Eligible professionals under the Medicare program are doctors of medicine or osteopathy, dental surgery or dental medicine, podiatry, optometry, and chiropractors. So a fairly short list. Medicare eligible, they open it up to some additional provider types. It's basically anyone who is Medicare eligible, as well as nurse practitioners, nurse midwives, dentists, and then physician assistants who provide care in a federally qualified health center or rural health clinic that they lead. In order to qualify for the Medicaid program under Meaningful Use, you have to have a minimum 30% Medicaid patient volume, unless you're a pediatrician, which in this case obviously doesn't matter, or unless you provide care in a federally qualified health center or rural health center and have a minimum 30% patient volume that's attributable to needy individuals. So you have to choose one program or the other, decide whether you're going to enroll in the Medicare program or in the Medicaid program, and you can switch once during the Meaningful Use program. So here's the Medicare payment schedule. Those that qualified last year and attested last year already received a payment or will soon receive a payment of $18,000. And you'll see it totals between the period of 2011 and 2015, they'll be eligible for a total of $44,000 per provider. And the good news is that if you didn't attest for last year, but you do attest for this year, you're still eligible to receive that $44,000 payment. You'll just have to end up being paid between 2012 and 2016. If you don't attest for this year and you start in 2013, you actually see your total drop. And it's not significant. It's only $3,000, but you do miss a little bit of the incentive payments that are being offered if you don't start Meaningful Use until next year. That would be, I think there's going to be a big push to get everyone to attest this year or next year, because if you don't start till 2014, you see a pretty significant drop, almost 50% in the amount of incentive payments you'll receive. So really what we're trying to say is, there is still time, but you definitely, ideally you would adopt a system this year and attest, and it's only a 90-day period for this year, and you would be eligible to receive the maximum payouts. And the Medicaid payment schedule is actually a little more friendly. At this point, it doesn't matter what year you start, you're still entitled to a total of $63,750. So the Medicaid pays out better, and they're not as interested in when you're starting, simply that you do start and then eventually meet meaningful use. So their payments don't go down over time. So what does it take to meet meaningful use? For stage 1, there are 2 categories of what are called objectives. These are things that you have to meet in order to meet meaningful use. So in stage 1, there are what are called core objectives, and there are 15 of them. They are not optional. You have to meet all 15 unless you can claim an exclusion, and we'll talk about exclusions in just a moment. But in essence, just think of these items as things that you're going to have to do as long as they are relevant to the care you provide. There are also 10 menu objectives. You only have to pick 5 of the 10. So you don't have to meet all the menu objectives. You get to pick and choose, though one of the 5 must be focused on improving population health, and I'll show you in a little moment what the population health objectives are. In stage 2, they change things up a little bit. Basically, in stage 2, everything that was core in stage 1 stays a core objective in stage 2. So if you did it in stage 1, you're going to have to keep doing it in stage 2. Most of the menu objectives from stage 1, the things that were optional, become required in stage 2. So things that you may have been able to avoid in stage 1, you're going to have to do in stage 2. And then they set up some new menu objectives for stage 2. There are 5 of them, and you have to meet 3. So in either stage, there are 20 total objectives that you need to meet, again, unless you can claim an exclusion. They're just broken up a little bit differently based on which stage you're in. Since right now, I imagine everyone on this call is going to be focused on stage 1, you're going to need to choose an EHR and meet the stage 1 requirements. Let's talk about the objectives. So your core objectives, first one is computerized physician order entry, or what we call CPOE. And in your case, that might be what we would consider an exclusion. And to keep in mind, if I mention something that's an exclusion, I certainly can't guarantee it'll be an exclusion for you, but it's something you would be able to look at and say, hey, I might not have to meet this one, and that certainly makes meaningful use easier to meet if there are objectives that aren't relevant to your practice. So physician order entry, really that's just entering medication data into the EHR. And again, it might be an exclusion in your case. Implementing drug-drug and drug allergy interaction checks. There is no exclusion here. You have to meet this one, even if you don't write prescriptions, which I find kind of unusual. But even if you don't write prescriptions, you are required to have an EHR that can do drug-drug and drug allergy interaction checks. The third core objective is e-prescribing. Again, might be a possible exclusion for you if you don't, essentially if you write less than 100 prescriptions, any physician that writes less than 100 prescriptions during the meaningful use reporting period, which is 90 days for the first year you attest, then you can be excluded from that particular objective. So electronic prescribing, it's quite possible you'd be able to be excluded from that. According to demographics, maintaining an up-to-date problem list, maintaining an active medication list, and an active medication allergy list. Those are all fairly easy ones to meet. Vital signs, if you don't take vital signs, is another objective you might be excluded from. Recording smoking status, implementing one clinical decision support rule. That one I think is a bit cryptic to people who may not have used an EHR or may just not understand what a clinical decision support rule is. That's just really a function of the EHR that actively gives you information that can help you make decisions about patient care. And the best example of this is what we consider health maintenance. Those procedures that a patient ought to have done on a regular basis based on their age and sex, or maybe a medication they're taking, or perhaps a particular problem they've been diagnosed with. So the system needs to be able to prompt you with some information or provide you with some information that helps you make decisions about patient care. Reporting clinical quality measures, I didn't list an exclusion here because there really are no exclusions to clinical quality measures, but many of the clinical quality measures probably don't apply to orthopedic practices, in which case you still have to report your numbers, but in many cases your numbers may be 0 over 0. You haven't seen any patients that these apply to. So again, it might make the process of meeting meaningful use easier in your case. Providing patients with an electronic copy of their health information, that's always a possible exclusion based on how often you have patients requesting copies of their data. Providing clinical summaries for patients, that's just basically an overview of their visit. They come in, you see them, you document your visit, and then you provide them with a summary of that visit, ideally before they leave your office. That's required. To electronically exchange key clinical information, that is one of the big pieces of meaningful use is health information exchange. You may have seen it abbreviated as HIE, but being able to send data out of your system to, in most cases, another vendor's, another practice's system that's probably built by a different vendor, and whether that be another orthopedic practice or a primary care provider's practice or a hospital, what have you. Really just the ability to exchange data with that other entity. And then finally, the ability to protect electronic health information created or maintained by your certified EHR. Sometimes this is called security risk analysis, just the ability to ensure that your system is secure, your data is secure, that you're doing what's necessary to protect your patient data. So those are the 15 core requirements. You have to meet all of them unless you can claim an exclusion. Here's the menu set, and you have to pick 5 of the 10. The first is implement drug formulary checks. You don't write prescriptions. That's really not even applicable. Incorporate discrete clinical lab results into the EHR. We've got that listed as a possible exclusion depending on whether you order labs or not. Generating a patient list by condition. So if you've got a segment of your population that suffers from the same kinds of issues, you can put them into a patient list. That's one of the options you've got. Sending reminders to your patients for patient preference. That means, does the patient want a message printed? Do they want to be called? Do they want to be sent a message electronically? So the ability to send them reminders. Providing patients with electronic access to their health information. That means having a patient portal that's available where the patient can log on over the internet and see their at least some subset of their clinical information that you've got on the patient portal. Using the EHR to identify patient education resources. Providing a summary of care record for transitions of care. I skipped medication reconciliation. Providing a summary of care. Submitting data to immunization registries. That's a possible exclusion in your case, and submitting surveillance data, or what we sometimes call syndromic surveillance data. The last 2 items you'll see they have little asterisks after their names. Those are the population health measures. You're required to pick one of the 2, though if it's not part of the way you typically care for patients, then you would be able to claim an exclusion from whichever one you select. So you get to pick 5 of these 10. And if you have items that you are excluded from, you can actually select those and then claim an exclusion, which certainly makes meaningful use a little bit easier. So let's talk a little bit about key stage 2 changes to meaningful use. So if you get through stage 1 and you move on to stage 2, most of the performance objectives, and when we talk about a performance objective, many of the meaningful use objectives require that you meet some threshold. You have to do something 50% of the time or 10% of the time. So in stage 2, they've raised the performance objective percentages or the thresholds for the vast majority of them. So it definitely becomes more difficult in stage 2. You have to do certain things more often, but if you can meet stage 1 and you can build it into your workflows to capture the right data for your patients, then meeting stage 2, I don't think, for most of the objectives, I don't think will be a challenge, because as long as it's part of your standard workflow and as long as your staff, your physicians know what they need to be capturing, and if they're doing it on a regular basis, you're not going to have issues meeting the thresholds. But they do increase in stage 2. They increase the clinical decision support rules. They change them. The name of it changes from rules to interventions, but the concept is the same. You need to have your EHR prompting you or providing you with data that helps you make decisions about patient care. They up that from 1 to 5, and you do have to do drug and drug allergy checking. Again, it may not be appropriate for you, but it's got to be installed. It's got to be active regardless of specialty. Patient portal, that becomes a required piece in stage 2, so you have to have a patient portal where your patients can go and view their data. Immunization submission is required. Again, it may be quite possibly an exclusion in your case, but that becomes a core objective. And then there's a new core objective in stage 2 that requires 10% of all of your patients to send secure messages. That's a big one. That's part of the patient engagement. The portal and the messaging are 2 pieces in stage 2 that they are going to require, because they want you to engage your patients more. They want you to make sure that the patients have the ability to get to their health information, and that you are encouraging them not only to view their data but to interact with you about their care, and be able to do that interaction without having to schedule an office visit and come in and sit in an exam room and talk to a physician. So that's the messaging piece, is the ability to communicate with our provider electronically. And there are some new menu objectives. Again, these may not be relevant for your particular specialty, and if not, you'd be able to claim exclusions, but we're talking about being able to view more than 40% of imaging results in the EHR, recording family history for more than 20% of all patients, and then the ongoing transmission of cancer case information or specific care information to registries, and that's really part of the health information exchange piece. They want you to have the ability to submit data that you've captured in the EHR to public health agencies, cancer registries, or other registries. So looking at the timeline, the stage 2 recommendations, right now, well, I should back up. In June of 2011 is when the recommendations were first made. The proposed rule was released in February 23rd. We're looking at late summer of this year to get the stage 2 final rule, and we'll know what really needs to be done, because right now they've released a proposed rule, but there are undoubtedly going to be some changes. And then starting in most likely for you, 2014 is when you would have to meet stage 2. So if you start this year, you'd have a couple of years on stage 1 to get your processes down, get your workflow worked out before you'd have to start in on stage 2. Backing up to stage 1, though, the main thing that I stress to clinics that haven't started is that it's not too late to start. A lot of people come to me and say, we didn't attest last year. We didn't meet meaningful use in 2011. Have we already missed out on some of the money? No. If you attest for the first time this year, and it's a 90-day period, you have to report on a continuous 90-day period the first year you attest. If you do that this year, you're still eligible for the full incentives for your providers. So, just keep in mind that it is not too late to start. You do have to choose either the Medicare or Medicaid program, and you can change once during the meaningful use program's lifespan. Some dates to keep in mind. October 3rd of 2012 will be the last day for eligible professionals to begin your 90-day reporting period. So if you do want to attest for meaningful use this year, you've got to be up and running on an EHR and start measuring your data October 3rd. And so ideally you'd want to be up even earlier just because it's going to take you some time to get your processes down, to get the right data captured in the EHR. There's certainly time to do that. October 3rd, I think is a ways away. And even if you don't do so well your first couple of weeks or even your first month, you've still got a couple of months in that 90-day period to make up for it, to figure out where your workflows may need improvement, where you need to remind staff to capture certain pieces of data. So you've certainly got time, but October 3rd is when you need to start at the very latest. December 31st is when the reporting year is going to end, and you have until February 28th to actually attest. So you do your 90-day period, and it doesn't matter when in this year you do it, but you actually have to go to the CMS's attestation website and key in your performance metric data no later than February 28th of 2013 in order to prove that, yes, we were using the EHR in a meaningful way. Just a few statistics. As of the end of February of this year, 211,500 eligible providers, hospitals, and critical access hospitals have registered for meaningful use, and over 62,000 of them have been paid already for meaningful use. And they've already paid out $3.8 billion in incentive payments to providers and hospitals. So they've already paid out a ton of money. It's there. It's just a matter of adopting the EHR and using it in the right way. And Practice Partner, and we've got a couple other EHRs that are essentially the same program but just branded a little differently. We've got a program called Medisoft Clinical. There's also Lytec MD. They link up to various practice management programs, but we've got several programs that are ONC certified, so we have been certified for meaningful use. Practice Partner in this case is a fully integrated EHR and practice management solution. It's got scheduling, it's got billing, and it's got the electronic health record, or EHR. Certified. It's an ANSI 5010 enabled solution. Our Medisoft Clinical and Lytec MD programs, which are essentially the same EHR but with different branding, they link up to different practice management programs, but they are also certified for meaningful use. So we have solutions. They are certified for meaningful use. You can meet meaningful use using these products. Practice Partner is a flexible solution. It's proven to enhance visibility to your patient population and complement your practice's unique workflow. And one of the pieces that I think really sets Practice Partner apart is BrightNote technology. And this is the idea that you can essentially chart everything you need to about a patient in a single note. You can put in information about their medications, their problems, their health maintenance, all in your note. And then at the time that you save that note, all of that information gets disseminated to the various pieces of the chart to ensure that all of your information is captured. It's searchable, but it's also very easy to enter because you can do so in one place. And it doesn't matter whether you want to dictate your information using some kind of a service that will type up your notes. You can use speech recognition. You can free type everything, or you can use what we call templates, which are pre-built standard pieces of information, or really I would think of them as generally problem-specific templates you can pull in that will present you with the information you need to record about a particular visit. All of those options are available, and regardless of which option you choose, you have the ability to take advantage of BrightNote technology, where you can record a massive amount of information about a patient visit and have it then go to the various pieces or places in a patient chart. So at this point, I think we'll open it up for any questions you might have.
Certainly, Mr. Wilson. Well, ladies and gentlemen, if you wish to ask a question, please press star then 1 on your touch-tone telephone. You'll hear a voice prompt letting you know your line is open, and we do ask that you please state your name before posing your question. Also, if you're joining on a speakerphone, please make sure your mute function is turned off. Once again, that is star 1 for questions. Once again, that is star 1 if you would like to ask a question. As a final reminder to the audience, that's star 1 to ask a question. We'll go ahead and pause to give everyone a final opportunity. Caller, please go ahead. Your line is open.
I'm sorry. We'd just like to get a copy of the presentation. Will that be mailed out to all attendees?
Hi, this is Holly Wilson with McKesson. Yes, following the webinar, you will receive an email with the slides as well as a recording of the webinar. So you should receive that by tomorrow.
Wonderful. Thank you so much.
Great. Thank you.
This has been wonderful. Thanks.
We'll turn to our next caller.
Yes, my question is around, have you seen any obstacles in meeting of the meaningful use criteria, seeing that a lot of them were geared towards primary care, meeting them for orthopedic practitioners?
Well, as I mentioned before, anything that's not relevant to your practice you can claim an exclusion for. I mean, you certainly have to have a valid reason to be able to say, this is not part of our practice, we don't do this standard, and be able to present that when you go to a test. But there are many specialists that have been able to attest for meaningful use with no problems at all. So really, it's just a matter of if you're a specialist and you want to meet meaningful use, just be sure that you really dig into those particular items that you believe you can claim an exclusion for, and make sure that you really can claim it based on the CMS's final rule. And I mean, they've posted a lot of information out there in various frequently asked question lists and other things. So you can go out and get the information you need. Just make sure that that if you're going to claim an exclusion, that you can do so and know that there's not going to be any questions about it later. But many specialists have been able to attest for meaningful use with no issue.
Anything else, caller?
No, thank you.
No further questions.
All right. Well, thank you, everybody, for joining us today. And I'd like to thank our speakers, Dr. Razzouk and Philip Wilson, one more time. Thank you for the information that you provided today. And with that, we will go ahead and end the call. Thank you.
And again, ladies and gentlemen, that concludes our conference for today. We thank you all for your participation.